Hi guys, it is week 8. It is time for embryology. It's the winter of 2021. And important day today. We're going to start talking about forming the notochord as well as we're not going to finish, but we're going to start talking about neurulation as well. So two very important events. And remember where we were last time? We formed a primitive streak. We had the hypoblast cells wake up, and we talked how they wake up, move to the midline, pile up and in the midline, and then they start piling forward and forward and forward, and they become the primitive streak. And then an extra big pile of them occurs on the end for the primitive node, and then a primitive groove develops, kind of a trough in the middle of them, and a primitive, the primitive groove develops, and that was what we did last time. Remember, this occurs on the surface here of the epiblast. And these are hypoblasts. These are epiblast cells that wake up and migrate in. And then we talked about how once the streak is formed, they start migrating through the center and go down underneath this epiblast layer. Right, and that's what's formed there, the primitive node and the primitive streak. This is called the primitive pit. That's what I couldn't think of. The primitive pit is also formed. That's basically caused by these epiblast cells migrating and then diving down through this structure. And it kind of doesn't hollow it out, but it digs a trench in there from the migration. And here's a side view of this happening where we have hypoblast cells. Remember, they're modified. They're turned into bottle cells, and they become mesenchymal, and then they go all over. They form a new mesoderm or intraembryonic mesoderm here. Some of them march forward here, as we're going to see here in a second, to start to form the notochord. Right? But they keep going, and they replace the hypoblast layer. They're going to form the 3 germ layers, and so we're going to get a endoderm formed here, and then a mesoderm formed in the middle, and then the very top cells. Here's a better picture of that. So we can see these modified epiblast cells, just mesenchymal cells at this point. Remember, if they got exposed to high levels of BMP, they went all the way down, kicked these original hypoblast cells out of there, and took over and became the first germ layer, which is the endoderm. And then the mesoderm was built here in the middle because they're exposed to low levels of nodal. And it's controversial what happens first, right? Does the mesoderm form first, or does the endoderm form first? Or they probably form together. In humans, I don't think we really know for sure. But we do know once these 2 germ layers are formed, the mesoderm and endoderm, the ectoderm occurs. And these are hypoblast or epiblast cells. Once all this is completed, the epiblast cells just morph into the 3rd germ layer, which is the ectoderm. And what is the fate of the primitive streak? Well, it actually about the start of the 4th week, it actually starts shrinking and kind of going back to. Do I have a picture of it? Going back to where it came from. So about the 4th week, it starts going this way and getting smaller and smaller, and it slowly grew. It grew originally that way, about halfway on the back here of the little creature. But as it shrinks back, it's spitting out cells which will become notochordal cells here. So we're forming, as it shrinks back, we form a notochord is kind of the point there. Yep. So yeah, and then we do need to, if it doesn't completely degenerate away like it's supposed to, if some of it is left over, we can get a tumor called a teratoma. All right, let's put this section in here real quick. This is about the tail bud, and we're talking about this now because this happens as the primitive streak disappears or disintegrates. In fact, some authors say that gastrulation is complete via the formation of the tail, but we're not going to say that, but that's a European board book or a the European medical schools use Larsen. It's a great book, by the way, but we're not going to say that, but just for other people who are watching this, some people say that the formation of the tail bud officially marks the end of gastrulation. So what's the deal with this tail bud? So as the primitive streak is degenerating away, the very caudalmost portion of the streak all of a sudden changes, and we won't talk about how that occurs, but it gets exposed to certain gene products, and we won't even worry about it. But the cells morph into a kind of a into a kind of a mesenchymal-like structure that's ultimately going to form neural tissue. And that mass of new cells is called the tail bud. And it's going to occur right here. So here's our neural plate, which we're going to talk about later. Our primitive streak, remember the primitive streak used to be, there's the primitive node. It used to be way out to here, and now it's degenerated away. And there's the primitive node, or primitive knot, some authors call it. And there's not much left. And this tissue right here all of a sudden morphs into a clump of stuff called the tail bud. So why do I care about this tail bud anyway? The tail bud actually is going to be attached to the neural tube. The neural tube is your brain and your spinal cord. And for whatever reason, the process of forming this brain and spinal cord, it doesn't go all the way to the sacrum or to the coccyx. So we need a different process to happen. And you can see that all these cells we have a new crop of cells. And where do they come from? They came from the primitive streak. And they're going to morph into a tube-like structure and connect with this neural tube. And that process is going to be called secondary neurulation. So the primitive streak gives us one final gift. It actually makes part of the most caudal part of the spinal cord. That's the point there. What does it, let's see, what else? It's important to note that the tail bud does not give rise to the sacrococcygeal notochord. We're going to talk about that formation. That's a different story. Let's see. And just a final thing about the tail bud, it does give rise to things called sacrococcygeal somites, which we'll get to a long time from now, and neural crest cells. And this will make more sense. It's like, where do I put this in? I could wait and put it in later, but because we're talking about the degenerating primitive streak, I think it's a good idea to put it in now. And it'll make more sense when we get to that part. If the notochord, or if the primitive streak does not completely degenerate, it can be trouble. And specifically, the tissue that doesn't degenerate can start dividing almost like a cancer, and it becomes tumorous, and sometimes hugely tumorous. And that type of a tumor is called a teratoma. A teratoma. Specifically, it usually occurs in the sacrum. It's called a sacrococcygeal teratoma. It's rare. It's rarer than Marfan syndrome, 0.003% incidence of these things. But it does occur. You don't have to know this, but there's classifications of these teratomas, and you can see there's a bunch of them that do become malignant. Usually they're benign, so you don't have to worry about them, but they can cause paralysis and all kinds of trouble with the newborn. Let's take a look at some of these. So there's a teratoma in a newborn. That's actually not too bad of one, but because the primitive streak is associated with germ cells, some people call it a germ cell tumor, because really the primitive streak is endoderm-like tissue. And so it does have, they're stem cell-like, so it has the power to give rise to all cells. So that's not good to have a germ cell tumor, because it can give rise to all sorts of different tissue, muscle, bone, teeth, stomach glands, you name it can be found in these tumors, a hodgepodge of different tissues. So that's the deal with that. So let's see some of these studies, or some of these case studies that are presented in the medical literature. So here's a really big sacrococcygeal teratoma in this newborn, and they were able to cut it off and remove it. The baby lived, and as far as I know, was doing just fine. The histological examination revealed smooth muscle cells, skeletal muscle, skin, endocrine glands, lung tissue, glial cells, a bunch of connective tissue involved in that tumor. And here's a nice, you don't see this very often, a newborn x-ray. So that's a pretty rare x-ray right there, just to show you this. A teratoma. After the surgery, it looks pretty gruesome, but the baby lived, and neurologically they were fine. At least when they left the hospital, there was no follow-up on it. But all right, as I said, they're usually benign, but sometimes they can be malignant. They can grow inward as well and cause small bowel obstruction and urinary obstruction. They need to be taken out. These are really common in females. About 80% of them show up in females, and they need to be removed quickly before they cause all sorts of trouble. And there's a nasty one that looks quite cancerous, and this was a bad one. I still think the child made it out of the hospital in this case report, but there's no long-term follow-up, so you don't know how these kids do. Okay, so we're going to start talking about the notochord next. So we need to know where we're at. So this is where we're at. This is that side view. I mean, this is the little human right here. Right now it's a bilaminar disc. Or no, it's a trilaminar disc, right? We made a mesoderm in here last time. So we have a trilaminar disc. We have an oropharyngeal membrane we made, a prechordal plate, the AV cells we made a long time ago, an ectoderm and endoderm here, cloacal membrane we made, and the mesoderm is in the midline. Mesoderm would be coming in and out of the plane of the page as well, which we can't see. There's kind of a blow up of it. So the next thing we need to do is make the notochord. So let's talk about the formation of the notochord, and this is basically what we're going to add to the picture. We're going to have cells streaking through the primitive node and making a beeline in the midline straight forward between the ectoderm and endoderm until they bump into the prechordal plate. And that is going to be a notochord. Right? So it's a midline structure. It develops in week 3. Between the newly created ectoderm and endoderm. Just said that. It takes about 6 days to form. So typically between day 16 and 22 is the formation of this. It's not a permanent structure, though. It's going to degenerate away, but it's going to leave us some presence, as we talked about. It's found in all vertebrae. In fact, to be in the vertebrae phylum Chordate, you have to have a notochord during development. It extends cranially from the primitive node to the prechordal plate. Yep, right. Is that true? Let's go look and see. Well, let's see. Here is the primitive node, and it extends up to the prechordal plate. Yes, it sure does. And it grows caudally. So, and that's kind of a weird question in a way, because it really starts because the primitive streak is caudal, right? And this is cranial over here, and that's caudal here. So it very quickly it grows from caudal to cranial, but once it bumps into the plate, it starts when it hits the plate and it's a straight line like this, the primitive streak starts going backwards. And so the rest of the growth is cranial to caudal because it's going to grow like this as the primitive streak shrinks, if that makes sense. And yeah, this is a terrible mess. The formation of the notochord is the worst. The authors are all over the place. Even the Moores and Langman, the 2 chiropractic board books, conflict. Really poor job. The European board books, Singh and Larsen, kind of saved the day when putting this part of the program together. So shame to Moore and Langman. All right, so basic. What does the darn thing do, and why are we even talking about this? Well, it's going to be like a little spine, sort of, for the little trilaminar disc now, the little human, the little embryo, if you will. So it does provide some axial support. It induces the formation of the neurotube, so it's very important. It's going to be a signaling center, in other words, to help form the neurotube, which is going to become the brain and spinal cord. It also will help induce the formation of the vertebral bodies, and its remnants actually become the nucleus pulposus of the intervertebral disc. And we'll talk about that. So we know the nucleus pulposus, right? That originally, in a kid like 4, 5, 6, 7, 8 years old, they have notochord cells in the center of their disc. I think we've talked about that a little bit. So how do you make this notochord? Well, there's a second anterior line of kind of an anterior midline migration or cranial migration. Remember, cranial and anterior are AKAs when in the embryology world. So the second wave of hypoblast cells, which become mesenchymal, they come out of the primitive node, and you're forming the mesoderm at the same time this is happening. But this form of waves goes straight forward, hits the first stream of waves, form the prechordal plate. Remember that? And the second wave is going to form the notochord. That's good to know what the first midline cranial stream of mesenchymal cells formed. The first is the prechordal plate. The second is the important notochord. That forms before the mesoderm and endoderm. All right, and we said they pile up, they hit the prechordal plate. That first structure, by the way, is not the official notochord proper. We have to go through a metamorphosis to get to the finished version. So the first kind of baby notochord is called a notochord process. Some authors call it the head process. And here's kind of a cutaway, and we see cells, hypoblast cells would be coming this way, morphing into mesenchymal cells, and then heading straight forward to form. And as this is going to shrink back in time, this expands as it shrinks back. There's another view. Same thing. We got the cells going forward. It's going to bump into the prechordal plate. And yeah, some mesoderm cells are kind of sneaking around here. But now, out of the plane of the page, this would be all filled up with mesoderm. This is just happening in the midline, right? Got to think three-dimensionally. We've got to do a few genes here. There are two main genes that have to be turned on in these future notochordal cells. That's the FOXA2 gene. The real name is forkhead box protein A2. And then we have the brachyury gene. Strong AKA is the T gene. Both of these genes need to be turned on in our future notochordal cells. This one is more of a protector that protects the cells as they pass through the primitive node, which can be a rough journey. The FOXA2 gene actually has the instructions. It tells them to stay in the midline and migrate forward until you bump into either the prechordal plate or bump into the neighbor. And don't spread laterally, just stay in the middle. So as we said, as the notochord, as it reaches the full length, the primitive streak starts to go backwards or shrink away. The official word for that is regress. It regresses in a cranial to caudal direction or in an anterior to caudal direction, depending on the author's choice there. And as it regresses, the notochord cells keep streaming out, and that elongates the notochord. So as the primitive streak shrinks, the notochord elongates. That's a nice test question, is it? Or true or false? As the primitive cord shrinks, degenerates away, the notochord lengthens or elongates. That's absolutely true. All right, we talked about that. So the notochord mainly elongates in a cranial to caudal direction, while the primitive streak regresses in a cranial to caudal direction. Remember, the primitive streak elongated in a caudal to cranial direction. Isn't embryology wonderful? Right, so now here's that kind of picture, and you can see there's not much left. Only the primitive node, most of the primitive streak is gone, and the notochord has gotten much longer, and it's elongating as this streak is shrinking. All right, so what's the first thing that happens? Now we have a pretty good notochordal process that's grown here. It's solid right now. First thing that happens is we're going to form a hole inside of it. We're going to form a lumen. We're going to narrow that out. And that lumen is going to be called the notochordal canal. Right? So notochordal canal. Once a notochordal canal develops, the notochord is now a tube. So boom, just like that, there's our notochordal canal. In our notochordal process. And yeah, so what happens next? Fusing to the endoderm. So the notochordal canal now increases in size. Basically, all these cells are going to erode, and the notochordal canal is going to come right down here under the newly formed. It's going to connect to the endoderm, in fact. So it gets big, and then it fuses with the endoderm beneath it. Okay, so there it's gotten big, and it's fused with the newly formed germ layer, the endoderm cells. Wonderful. Why? So why does it do that? Well, where we're going with this, and let's remember in this picture, this is filled with amniotic fluid. This is the amniotic cavity here. This is the secondary yolk sac here, or you could say it's the secondary yolk sac cavity. So this has juice in it. This has juice in it. And we're going to erode some of these cells away, and we're going to form an open cavity, an open communication between the amniotic cavity and secondary yolk sac. And we're going to let these two juices mix together. And it turns out we're not going to get crazy into the weeds because they just don't, in humans, they just don't understand this too much. But I'll show you the whole reason here. There's some pathology where you don't understand that. You won't understand this pathology, we'll see. That canal is called the neuroenteric canal. The neuroenteric canal. Let's see a picture. So now not only has the notochordal canal fused with the endoderm has degenerated and formed a passageway between the amniotic cavity and the secondary yolk sac cavity. Okay, so neuroenteric canal. So why in the world, who cares about this? Why am I even talking about this? Because there is a condition called diastematomyelia. That's a tough one. So diastematomyelia, where you have what's called a split spinal cord, and malformations with regard to closing this canal. If the canal never closes, you're going to get a split spinal cord, and that causes all sorts of trouble. All right, so neuroenteric canal, if it fails to close or fails to form, you get a split spinal cord, which is a condition called diastematomyelia. Got it? And here is a patient with diastematomyelia. And you can clearly see we're kind of getting used to looking at these axial views. Sure enough, he's got two spinal cords, and he's got all sorts of neurological problems because of that. So why am I mean, we're not neurologists. Why do I care about this? Because about 70% of people affected with diastematomyelia, they actually have a congenital scoliosis. So here is a patient of mine, actually, a little kid who has back problems, and parents are all worried about the scoliosis. And this is not from this country, this patient, but the first thing that popped in my mind is, have you done an MRI to make sure, because the little child can't walk. So first thing that popped in my mind is diastematomyelia, and sure enough, that's exactly what this little guy had. So this little the scoliosis, congenital scoliosis, is the worst, or is the least of the problems. You can see the nice little hemivertebrae right there all by itself. See that little one? But I have a YouTube. I used to teach that class on kind of advanced lumbar spine pathology. It's up on YouTube somewhere. Congenital scoliosis, I think it's called. There's a butterfly vertebrae there. Anyway, so these patients can come in with radicular pain, weakness in their lower extremities, and this can happen later in life too. It doesn't happen right away. This can happen in kids as they get older and even into adulthood, and they can get dysfunction of the bladder. So, but it's still rare. I mean, you're probably not going to see anything like that. This is the only case I've seen, and been doing this over 30 years. Only case I've ever seen of it. Okay, so now what's the deal with this notochord? So we have a hole, we have that neuroenteric canal. We need to plug that, right? So the juices have mixed, and now it's time to plug that thing up. So the next thing that happens is our notochordal process drops and flattens to basically plug or put a band-aid over that neuroenteric canal. And that's exactly what happens. So you see that all the cells have dropped and formed a plate, and our hole is now closed. But that's no good because now we don't have a notochord, so we need to reform the notochord, but we can't do that until we patch this. And so by mitosis, we basically fill this in with new endoderm cells. That wasn't very good drawing, but that's exactly where we're going there. And oh yeah, that's right, I did this for you. Okay, so it's fixed now. So now we need to reform the notochord because we don't have a notochord. So next what happens is the cells, the flat cells start to curl upward. They expand laterally and they curl upward to reform a tube. And here's a head-on view of that happening. So the hole is plugged. We used to have the hole right here, and it's filled. And now these cells are through mitosis are growing this way and dividing, and they're growing up and up and up. And pretty soon they're going to reform the cord like that. And here you can see it is reformed. I forgot to draw the ectoderm would be here, right, on both of these. These not just sitting in space because the ectoderm and endoderm are still present. But yeah, so as this process keeps going, we finally get a tube structure again. Great, so we went from a plate now to a tube, but that's not going to do any good. We need to fill this in with cells. It has to have the great signaling cells within it, and so that's what happens next. We basically fill in the tube, and we're done. We finally have a notochord, a solid notochord, and it's called definitive. When you hear definitive, that means that it's a mature structure. It's done with its evolution. And remember, this is all mesoderm too. Let's not forget our mesoderm. All right, so just like the primitive streak in the chordoma, if the notochord, that's going to disappear as well. And there's tumors of notochord. I guess before we do that, let's talk about, and I think I've talked about this before in spinal anatomy, but remember the notochord, the very degenerated remains of the notochord actually make up the cells of the nucleus pulsus in the human. But those cells don't last forever, which is very strange. Remember we talked about how the immune system is formed and it kind of checks off self and it sees those notochords. Check yourself. I won't attack you. It checks heart cells. Check self. Brain cells. Check. So these original notochord cells that are in the nucleus pulsus are self. The immune system knows who they are. Great. But after the age of 10, those cells completely degenerate away, and a new population of cells springs up. And they're not perfectly fibroblasts, but they're similar to a fibroblast cell. Yeah, so about 10, you get a new population of cells. They still produce proteoglycans just like the old notochord cells, so there's no difference there. And the trouble is, remember, the inside of the disc is completely avascular. So the immune system, this is the theory anyway, the immune system doesn't know who they are. And it's possible that if these nucleus pulsus cells get outside, or at least get into the periphery of the disc where the sinovertebral nerves are and the blood vessels are, the body's immune system will take a look at them and go, I don't know who you are. It's because they're created after birth, and you could have a wicked inflammation because of that, and a wicked low back pain, a discogenic low back pain, which we've talked about in spinal anatomy. And yep, that's the deal. Where do people, if these sinovertebral nerves are set off by an inflammation, where does the human feel the pain? It's perceived as low back pain, and commonly refers to the SI joint. It's commonly tricks people. Primary healthcare providers think it's an SI joint pain problem when it's not. It's low back pain. And it can refer to the buttocks and the anterolateral thigh. There's some research, not a lot of research, but there's some research that says it can be referred all the way down the leg. And I don't find that in my clinical practice that much. But it's certainly, in fact, in my own personal experience, at the beginning of the end of my L5 disc, it did refer. In fact, back in the 2021, or back in 2001 when this all happened to me, I thought I had pain right in my SI joint, and I thought it was an SI problem. I had no low back pain, but the disc was ripped and getting ready to pop and herniate. So here's kind of this what we've been talking about. So here's the new fibroblast-like cells making proteoglycans. Everything is good, but they just popped up. This patient's, say they're 10 or 12 years old or so. Remember the post here, there's the sinovertebral nerves there. Blood vessels are hiding underneath there. I kind of cover them up too much. But if you get an annular tear, then all these fibroblast cells go through the annular tear and they surround the nerves and the blood vessels. Blood vessels, of course, have blood in them. And the blood has the body's immune system in it. And the immune system goes, who in the heck are you guys? And you might get a wicked inflammation because of that. And that alone can cause horrible, horrible low back pain. That's called discogenic low back pain. And I have people have to have fusion. They have to have the disc basically removed and depressurized. That's what Tiger Woods, that was his. He had an ALIF. It's anterior lumbar interbody fusion. Had the disc basically removed. They don't remove the whole disc, but they take most of the nucleus out. I won't get into that. But so how do you see this? Is there anything we can do as chiropractors? Can we order anything to make the diagnosis of discogenic pain? You can. There's a test called provocative discography. And warning, don't ever order this test unless the patient is over 50% on the Oswestry Disability Index test, severely disabled, and he's been that way for a year. Then you can maybe think about it, because poking a hole in the disc is not good for the disc. A good chunk of those people who poke a hole in the disc, within the next 5 years, they end up needing fusion or discectomy because the disc is doomed. It wrecks the disc, so you don't want to do this. But, if you're thinking about fusion and you want to prove that the disc is the source of pain, you can have the pain management doc stick a needle in there. It's a very procedure that takes years and years to develop. It has to be a great doc to do this, to get it right. And they pump contrast inside the nucleus, and it highlights the nucleus, and you can see the nucleus. Should never ever pressurize more than 75 psi above opening pressure. I have seen pain management doctors go up to 150. In fact, a prominent one here in the Bay Area, back when I was in practice, actually caused a herniation. He ripped the back of the disc right open. He went up to 150, which is insane. Never used them again. So no more than, you get false positives too, never more than 75 psi. So here's a patient of mine a couple of years ago, horrible, horrible low back pain, and he was going to lose his house, he couldn't work, he's out of disability insurance, and he had to do something. So okay, let's order discography and see if the discs are ripped. You probably need fusion, but you should confirm that there is pain. And I forgot to mention, not only can you see the annular tears here, they should recreate the exact same pain when they pressurize the disc to 75. So you have to see the annular tear, so you can see the ship anchor here. Right? It's a grade 5 annular tear. Could be grade 4, but this one's actually leaking. If you look close, you can see the fluid has leaked right out of the disc. Right? That's a grade 5 annular tear. This disc has got a huge rip in it. This one's got a rip in it. So these discs were both shot. So ended up having a 2-level fusion. Anyway, we kind of got, you're just in first quarter, so I do like to teach that stuff, though. Missed that class. So what happens if a big portion of the notochord doesn't degenerate away like it's supposed to? No good. So that's called a chordoma. Chordoma, and it is a cancerous tumor. It's no good. And it's made of notochord remnants. The prevalence is super rare, 0.0001% of the population. So it's not out there that much, but it does account for 2% of all malignant bone tumors. It arises from the spine only, so it's a spine tumor. And it can be found in the sacral region or the cranial region, typically seen after the age of 50. 50% of these are in the sacrum, and they love to invade. They can get into it's a very invasive, like malignant melanoma loves to invade and metastasize and kill you. This is the same one. It likes to metastasize. About 40% of them metastasize. And in the cranial region, they can be misdiagnosed. They can look just like nasal polyps. Many people have lost their lives because of the misdiagnosis of nasal polyps when it was actually a chordoma. So here's a picture of a normal MRI. We've seen probably enough of these to know, okay, looks like a pretty good MRI there. And now look at this mess. So the tumor's just completely eaten away most of the sacrum, and the coccyx is gone, so no good. Here's a 33-year-old female comes in your clinic. Kind of a clinical today, isn't it? Left SI joint pain. What do you think? You take an x-ray? This is a tough one. It's a tough one because it looks like fecal material, but where's the rest of the sacrum? The sacrum, this is gas. That black stuff is gas. You can see the sacroala right through the gas just fine, the SI joint, but all of a sudden it's gone. So that's not normal. And I mean, this isn't really fair. You'd have the lateral view to look at to confirm that, this is all tumorous tissue here. All right, let's start some neurulation here. This is actually getting to be a long one, isn't it? Let's start the important process of building the brain in the spinal cord. So this process is called neurulation. And yeah, it's the process of forming a neural plate and then morphing the neural plate into a neural tube. And that's the process of neurulation. Still in week 3. Notochord is regressing while this is going on. So kind of 2 stories going on at the same time. And it's going to end by the end of the 4th week by the closure of that. We've already formed a tube in the middle, and the tube kind of forms going cranial and caudally and has these open ends. The open ends finally close. Those open ends are called neural pores, and the caudal neural pore closes the very last thing. So there's 4 stages of neurulation. Let's take a look at. So we have formation of the neural plate from ectoderm. So we have to turn ectoderm into neuroectoderm, and then we have to make this plate into a key-like structure. We actually have to elongate the plate, as we'll see, and then we have to fold the plate, kind of like we did the flat notochord, how we bent the sides up and formed a tube. We're kind of going to do the same thing with that. We need to make a tube out of it, and then we need to fill it in to create basically, once it's all filled in with cells, and we've created these magical neural crest cells, it's basically done at that point. So let's get to it. So first thing we need to do is form the neural plate. So this happens on day 18. Primitive node and the notochord release gene products that soak into the ectoderm cells above. In other words, they induce ectoderm cells to morph into a neural tissue. And so ectoderm cells above morph into a neuroectoderm cells. And basically they get very thick and form a plate above. And that's called the neural plate. The neural plate is made from neuroectoderm cells. Right, so here you can see the notochord in this slice. This is a head-on coronal slice. Again, this would actually be an axial slice, right? If it's head-on, wouldn't be coronal, it would be axial or cross-sectional view. I just caught that. But you see some of the gene products. We won't worry about the gene products right now. But they soak in all these pretty blue cells are ectoderm cells, but these got exposed to the juice and they turned into neuroectoderm cells. They got very tall, and yeah, so they morphed into neuroectoderm cells. And this conversion is called neural induction. We said that already. And collectively, these cells, said this already too, they make up the neuroectoderm. So neuroectoderm is made up of neuroectoderm cells. And the neuroectoderm makes up a structure called the neural plate. And that's the very first step in the formation of the central nervous system, the brain and spinal cord. This is all happening up here in the cranial region at first. And we can see the notochord right underneath this whole structure. Right? And there's the primitive node kind of behind it. Now this primitive streak here is going to start shrinking. As this starts shrinking, the notochord is going to grow longer, but so is the neural plate. The neural plate's going to kind of look like a key-like structure pretty soon. Right? You can say this neural plate is between the primitive node and oropharyngeal membrane. Yep, that's the same place the notochord is, right? Right. Just shows you the primitive node, oropharyngeal membrane. Yeah, and then, yeah, everything we said already. Okay, so who are the players involved in this neurulation? So there are 4. The big one is the notochord. The primitive node is important, but the precordial plate and anterior visceral endoderm, they also are involved, but not as much involved, but they do secrete some juices that swim. The juices swim quite a ways away. So the main player, I mean, I could probably take those out of there. The main player by far is the notochord. And primitive node is important as well. So what's the trick to making a neuroectoderm cell from an ectoderm cell? Well, we're back to our BMP4 again. You need to turn it off. So without BMP4, the neuroectoderm will morph into a default state, which is neural tissue. And who does that? Well, some of the BMP inhibitors that we already know, nogadine and cordon, are secreted from the primitive node. Mainly out of the notochord comes Cerberus 1. Lefty 1 is in there, but that's not the main one. It's Cerberus 1 is the big BMP inhibitor. So these are the 3 main ones that are responsible for creating neuroectoderm cells. Little histology: to create a neuroectoderm cell, you can't have the cadherins, the E-cadherins. There's a difference. We talked about cadherins in these junctions between cells, like the desmosomes, tight junctions, things like that, all made of cadherins. Specifically, they're made of E-cadherins. And if you want to create neural tissue, that won't work. So those gene products also cause a metamorphosis where the genes for E-cadherins stop working and the genes for N-cadherins turn on. And they're structurally a little different. We won't get into it, but just know that you have to switch E-cadherins to N-cadherins to make neural plate cells. All right, so what does the neural plate do? We've already said this. Could take this slide out of there. It creates a neural tube. The neural tube gives rise to the brain and spinal cord. Brain and spinal cord are the CNS, so the question could be a couple different ways. But the neural plate will morph into the CNS, right? Or it could morph into the brain and spinal cord, however you want to say. The retina of the eye is also comes from this setup as well. That's probably, that's on your own studies for boards. You got some work to do with embryology. I can get you the basics and get you understanding things, but you do have some work to do. I'll get you through the hard stuff. Elongating, the step 2 was to elongate the plate and make it key-shaped. And so this neural plate is going to look like a key. That's exactly what we'll do next. And so what's the deal? How does that happen? So the wide part of the neural plate immediately starts to grow caudally. So these cells start to migrate down, almost like 2 kind of notochords going on. But they never get nice and wide like the plate does, the neural plate does. They stay more narrow. And the question is, why do they stay more narrow? And that brings us to a topic called convergent extension. So this elongation process occurs via convergent extension. And that just means that as new tissue is made, it's compacted together. It's not loose like the original tissue is, so therefore it doesn't have the width anymore. And in fact, being tight together has a name. Those cells are called they're intercalated, which means they're locked really strong to each other and pulled together, so they make it narrow. And there's other examples in the body where that happens too, which we won't have time to get into. So there are some receptors involved in this. I'm not going to, this is really, really complex, and this is for chiropractors, probably for all medical, physical therapy, acupuncture, it's probably too deep. I'll just mention it though. The planar cell polarity pathway is what controls convergent extension and intercalation. So this is the actual workhorse that does it of genes. It's called the planar cell polarity pathway. And involves mainly Wnt, the gene product Wnt. Remember, that's the one that turns on nodal, right? But it does other things. Wnt can bind to these, the fizzled, the seltzer, and the Vangal, I call them. It can bind to these receptors, and it causes these cells to intercalate and be tight together. So that's all I'll say about that. We don't need to know any more about that. And you can see, yeah, this fat part here, the plate part of it, that's going to become the future brain, and this narrow part is going to be the spinal cord itself. Okay, we did it. So a lot of stuff to think about. We'll finish this story because this plate's not going to do us any good until we roll it up into a neural tube. So we'll finish neurulation next time.